This is Deb again. This is the part 3 of the Unit 2 Fluid and Electrolytes. We're going to talk about fluid balance. So we had the conversation in class about the difference between isotonic, hypotonic, and hypertonic solutions. Isotonic just means that it's the same as what's normally in the system. And so an example would be 0.9% normal saline. So if it's the same on both sides of a membrane, the fluid's not going to move anywhere. Everything is the same on both sides. So isotonic, everything stays put. Hypertonic is a high concentration solution. Example would be 3% normal saline. So if you administer a hypertonic solution, the concentration in the blood becomes higher, more concentrated, and then what happens is water moves from low to high concentration. So water is going to come in from the interstitial tissues and go into the blood. Remember, we're talking about compartment to compartment here. So what's going to happen to your patient if you administer a hypertonic solution? Their blood pressure is going to go up. Their cardiovascular system could become overloaded because of the shift of all this fluid into their blood. All right. If you administer a low concentration solution, a hypotonic solution, so it means very dilute. An example would be 0.45% normal saline. If I administer a low concentration solution into someone's blood, the blood becomes dilute, less concentrated. Water moves from low to high. So water will begin shifting out of the cardiovascular system out into the tissues. So what's going to happen to your patient? Their blood pressure is going to go down and they're going to have edema. And it could have edema almost everywhere. So the biggest thing I want you to take away from this is just understand what direction things are going to go. There is a consequence for anything that we administer to our patient. So just think about what would happen to your patient if you administered those concentrated or dilute solutions. There's a lot of thought process that goes into deciding what solution is appropriate for a patient. We always start with isotonic. That's the least change to the patient's system, unless the imbalance is significant. So we've talked about a normal serum sodium level is 135 to 145 milliequivalents per liter. If your sodium imbalance, if you have a low sodium level and say their sodium level is 120, that's a pretty significant significant level. You might consider giving them a hypertonic solution temporarily, but you've got to understand what's going to happen when you do that. Water's going to shift in to try to dilute it. All right, if you've got a patient that has a serum sodium level of 160, that's significant hypernatremia. You might consider temporarily giving them a hypotonic solution, but you have to understand what's going to happen when you do that. Fluid could begin shifting out into the tissues if you dilute it too much. So the takeaway for this course is we always start with isotonic. If your sodium level is out of range by a few points, then we always start with isotonic. If it's significant, 5 to 10 points out of range, then we might consider the other two. And here's just another, remember we talked about osmolality, measurements of concentration by volume and weight. This is just another diagram that depicts this. We've had a conversation about serum albumin, which is a blood protein, and oncotic pressure. Normal serum albumin level is 3.5 to 5.0 grams per deciliter. We talked about oncotic pressure, which is the pulling power protein has for water. This opposes hydrostatic pressure. So if you've got high pressure, this will oppose things leaking out and help keep water in the space where it needs to be. It can prevent plasma water from leaking into the tissues, and its role is to maintain volume and blood pressure. All right, let's talk about the fluid volume issues. Fluid volume deficit and excess is just mainly they either have too much fluid or not enough fluid. And I think these two in particular make a lot of common sense because I either don't have enough water or I've got way too much water. So a fluid volume deficit can be a decrease in intravascular, interstitial fluid. Person could be have active fluid loss. They don't have enough fluid intake, and we've talked about older adults have an altered thirst mechanism, and so they don't always drink enough. May not have access to adequate fluids. The regulatory mechanisms that manage fluid have failed. We've talked about ADH that causes the kidneys to hold on to water. And then we've got fluid shifting related to sodium imbalances. And so this one really kind of goes with the high sodium level. Share a lot of the same symptoms, but this is surely they don't have enough fluid volume. All right, so let's spend some time about what your patient's going to look like. And again, some of the symptoms are the same as you saw with your patient with hyponatremia, or hypernatremia, sorry. All right, vital signs. If they don't have enough fluid volume, you expect their blood pressure to be low. Low blood pressure, low blood volume. Heart rate would be high. And you would expect them to be orthostatic. And you have talked about what orthostatic means. We talked a little bit about it in Unit 1, so make sure you know the criteria for orthostatic blood pressure. They could have changes in their weight. If their fluid volume is low, you'd expect their daily weight to go down. Skin and mucous membranes. You expect dry, sticky mucous membranes. You would expect furrowed tongue. Skin turgor would be poor, and we had that conversation earlier in the unit about skin turgor. It's not really a very good, it's not, that piece of information all by itself really doesn't tell you specifically this is what it is. It's to add it to the rest of it. And where you would check that would be on the clavicle. Now, as people age, they lose elasticity and they lose that subcutaneous layer, so their skin may not have turgor like a young adult. So again, it's a piece of information. It'd be nice to have a baseline, what it was like before they became with fluid volume deficit. Urinary output would go down. Fluid volume has gone down. You'd expect the urine to be concentrated. Measurement of urine concentration, the test would be specific gravity. A normal specific gravity is 1.010 to 1.030. You need to know that. All right. The higher that number is, the more concentrated it is. All right, so you expect that number to be elevated. Low urine output, change in color and concentration. You'd expect their neck veins to be flat. So normal neck veins, when people are lying down, you've done this in health assessment lab, when people are lying down, you should be able to just see the outline of it there above the clavicle on the neck. All right, this would mean that their volume is so depleted that it's flat when they're laying down. All right, let's talk about what would be expected urine output. We talked about what the urine's going to look like. We said the output's going to be low, and we said it's going to be dark and concentrated. But let's talk a little bit about what would be a normal urine output. All right. Normal urine output, for those of you who work in a hospital setting, everybody thinks normal urine output is 30 mLs per hour. It is not 30 mLs an hour. That is what is the bare minimum that's even acceptable for someone who's really ill. You and my normal hourly urine output would be about 60 mLs per hour. All right, so a lot of people we don't do hourly outputs on. So how does 60 mLs an hour translate to at the end of an 8-hour shift? And yes, you need to do the math. How would that translate to normal urine output for a 24-hour period? So then we can look at it, and if urine output is below those acceptable limits, then we have an issue with renal perfusion. The kidneys are not getting blood flow related to the low fluid volume, and the urine is concentrated. The kidneys are trying to hold on to whatever fluid they've got to maintain balance. So you can look at that urine output and say, we've got a huge issue here because the kidneys aren't even producing what they need for the bare minimum. Sorry, I want to go back here. All right, let's talk about lab values. Electrolytes, if I've got low fluid volume, I've got less water, and so all the stuff is going to be more concentrated. So expect their, hang on just a second. Sorry for the interruption there. All right, let's talk about lab values. If you have low fluid volume, you expect electrolytes to be more concentrated, particularly sodium. So you expect sodium levels to go up. You'd expect their osmolarity to increase as well. It's a measurement of concentration. We already talked about specific gravity. You would expect, because of the loss of volume, hematocrit, which is the number measuring the concentration of red blood cells, you would expect that to increase. The number hasn't increased, but the concentration has. Hemoglobin might increase a little, but the hematocrit more significantly. Potassium, as sodium goes up, might go down. Blood urea nitrogen, which we haven't talked about yet, we'll talk about that more in Unit 4 with renal function, may go up as well. Medical and nursing management. Medical management, you expect if they're dehydrated, they need fluids. Generally, they'll put them on some IV fluids. Probably, if you look at the picture here, this is D5W, which is considered isotonic, the one that's least invasive. Generally, you give patients a liter or two, and they just feel dramatically better. We've done all our assessment information. All right, and we're going to monitor labs, particularly those ones we just got done talking about: sodium, osmolality, and hematocrit. All right, we would do intake and output. You would expect that their intake initially would be high, urine output would be low. As treatment was working, was effective, you'd expect the urine output to increase. Specific gravity, which is the concentration, would decrease, and it would lighten up in color. If they're dehydrated, you're going to do good oral care. Because their blood pressure is low, their heart rate is high, we would expect them to be orthostatic. So you'd want to do a baseline blood pressure and then slow position changes, because they'll get dizzy and lightheaded when they stand up. Daily weight, you'd expect their daily weight, if treatment is working, to be low and would increase as their fluid volume increases. All right. Safety, particularly for older adults, If you think about what you know about older adults is they have a decreased thirst mechanism, so they might not be thirsty. They also have less fluid volume. Remember, older adults are like 40 to 50% fluid volume versus the rest of us, which are about 2/3. And so they are borderline dehydrated already. So we got to make sure that they get adequate fluid intake, even if they're not thirsty. We want to make sure that they've got plenty of fluids. Make sure that it's fresh fluids. Nothing worse than trying to drink a glass of water that's been sitting at the bedside for 8 to 12 hours because it just doesn't taste good. Fresh fluids, preferred fluids. Okay, so maybe somebody doesn't like water. Well, let's find them something else that they can drink that would still replace their fluid volume. All right, the other thing we want to make sure is that we don't go too far the other direction. It's very easy, especially for older adults, to give them too much fluid and then they try to find balance between not having enough fluid and then all of a sudden now their cardiac system is overloaded. All right, so make sure that you look at your nursing diagnosis in ACLY. Make sure you know what it means, what would be appropriate goals. How would you know that their deficient fluid volume is better? All right, your defining characteristics, and then your interventions, which we just had a conversation with. Make sure you read the textbook. Ignatavicius and ATI both have great interventions. All right, let's talk about fluid overload. How are you going to know they've got too much fluid? All right, so I want you to think back about what your person looks like when they've got deficient fluid volume. Blood pressure's low, heart rate is high, increased sodium levels, sunken eyes, dry sticky mucous membranes, low urine output, concentrated urine output. All those things tell me they've got a fluid deficit. They're dehydrated. All right, so think about this person now, and someone comes in and gives this older adult that's 80 years old, that's dehydrated, that looks dehydrated, has all the assessments indicate they're dehydrated, and gives them 2 to 3 liters of IV fluid in a very short amount of time. What would change in your assessment? You'd expect their blood pressure to go up. Pressure becomes high because you've got fluid overload now. The heart's still working very hard to pump all that extra fluid around, so heart rate's going to continue to be high because the heart is working really hard. Okay, sodium you would expect to start to dilute. You'd expect their specific gravity, the concentration of the urine, to decrease, so it's less concentrated. If the kidneys respond correctly, you expect urine output to go up. But if you think about older adults, old kidneys may not respond as quickly as young, healthy kidneys. Fluid is going to start leaking everywhere. All right, think about hydrostatic pressure. Fluid's going to start dripping out. You might hear crackles in their lungs. O2 saturation might drop as they develop pulmonary edema. That person would be short of breath, decreased gas exchange, their respiratory rate's going to go up. They would develop JVD, jugular venous distension. That means that fluid is built up so that those jugular veins, when someone is sitting up, you should not be able to see their jugular veins. This means that you can see them. They're standing out, you can see them. So when you go to clinic, I want you to start looking for somebody who's got JVD. They might become confused. And everything that we talked about can lead to mental status changes, confusion. And then we'd be worried about edema. All right. Causes of edema, we're talking about excessive accumulation in the interstitial tissues. The capillaries start to leak. You've got pressure. You might be diluting their protein level. Maybe their intake's not been good. They've got a decreased oncotic pressure. We talked this last week about those people that have blockages or lacking lymphatic blood or fluid flow, lymphatic flow. The fluid can build up in there and cause edema. Maybe someone's got a high intake of sodium, or there's medications that cause sodium retention. We talked about corticosteroids that cause sodium retention. Okay, you can have localized edema. You'd expect per gravity that water's going to go where gravity pulls it. So if someone's laying in bed, where would you expect to see their edema? On their back. Make sure you check their scapula. Make sure you check their lower back, the back of their legs. You turn them on their side. Where's that fluid going to go? You'd expect to see fluid shift to that side. You turn to the other side, the fluid eventually is going to shift to that side as well. So you're going to see edema where gravity is pulling it out in the tissues. All right. Generalized massive edema is called anasarca. And what that means is they've got capillary permeability. There is a huge issue with the way their circulation works, and they get head to toe massive edema. Generally can be related to heart function, renal function. There's multiple different causes for this. These are the people that come into the hospital and they've got so much fluid that they can't move anymore. It's in their abdomen and their joints and their face and their neck and their chest and every place else. And so they come in and they do this really aggressive diuresis with high doses of diuretics and increase their sodium to pull the fluid back into their blood. And so what happens is these people lose like 20, 30, 40 pounds of fluid in 2 or 3 days. The problem is once they've developed this type of edema, these people end up in and out of the hospital because the mechanisms don't work correctly anymore. All right, so clinical manifestations, what's your assessment going to look like for somebody who's had edema? You'd expect weight gain. You could have change in mental status. You'd expect their blood pressure to go up, have JVD, full bounding pulse, distended neck veins. They might have a cough. They might have shortness of breath. They might have crackles. They could have increased urine output, depending on where the fluid's at. They might develop ascites, which is fluid in the peritoneal cavity. They could have peripheral edema. If you think now you've got too much fluid volume, you'd expect their hematocrit, concentration of red blood cells, to decrease. And you expect your osmolality to decrease. So here's just some pictures of what you'd expect for somebody. There's a picture of distended neck veins there. And you can see there that person is sitting up in bed. You can see that really full jugular vein right there. If you've never seen pitting edema, what pitting edema means is that they've got edema and you press your finger in it and you can kind of feel it squish out under your fingers, and then you let your finger go and the divot stays there. It's kind of like memory foam. If you put your hand on a piece of memory foam and push down, and you take your hand out, your handprint is there. So they can have edema in the interstitial tissues that would be pitting. And the way you measure that, we used to measure it 1+, 2+, 3+, 4+. Well, that's very subjective, and what I call 1+, somebody else could call 2+, or vice versa. So a better way to measure this is to measure the amount of time it takes for that skin to return back to its original state. So measuring it in seconds or minutes, and sometimes it's an hour by the time you go back and it's still there. So then that becomes a bigger problem. All right, medical and nursing management. You will talk more about diuretics in the cardiovascular unit. There's several different classes of diuretics. If the kidneys are responding, then that would be a way to get rid of fluid. Put them on a fluid restriction. We've given them too much. Now we got to cut it back. All right. So when somebody's on a fluid restriction, think about this now. I may be increasing their sodium level to try to get some of this fluid to move out of their system, but they can't have anything to drink. So I want to make sure I do oral care, sugarless chewing gum, ice chips, small glasses of water, those kinds of things. So they don't totally not have any water, but they can have some. Dietary restrictions, probably salt substitutes. Avoid things that are high in preservatives. Evaluate non-prescription drugs, over-the-counter drugs, to see what their effect is on sodium restriction. Okay. So what are you going to do? Fluid volume excess nursing interventions. What are you going to do because this person has too much fluid? All right, so if you think about prioritization, airway, breathing, circulation, safety, which one applies to this person? What's the main concern? Main concern would be breathing because they're at risk for pulmonary edema. All right, so the first thing that you're going to do, priority intervention, would be raise the head of the bed because that immediately impacts their tidal volume and how well they're breathing. Keep the head of the bed up. Check their O2 saturation. Daily weight. Expect their weight to go down if treatment was working. Intake and output. Initially, intake is low, output is low, or high, excuse me. Intake is low, output is high. And then as this continues to work, we expect that to be intake low, output continues to be high. You want them to start excreting some of that extra fluid. You'd evaluate for edema, and you've got to identify how extensive that edema is. So if someone's got fluid in their lower extremities, edema, a lot of times what we would do is we'd just take a Sharpie and we would mark where the edema line was. So say it goes up about halfway up their lower part of their leg. We'd draw a Sharpie line there, and then the next shift could say, oh, it's the same, it's worse than it was, or it's better, it's going down. We want to increase their protein intake because the protein has oncotic pressure, which will help pull fluid to itself. We want to make sure we're taking care of their skin because wet, scoppy skin has a tendency to fall apart. Then all those skincare principles we talked about in Unit 1 apply. So again, look up your nursing diagnosis, excess fluid volume. They've just got too much fluid on board. What would be an appropriate goal? How would you know that that excess fluid volume was better? And then what are the things that you're going to do? All right. Here's a couple of quick quiz questions. I'll let you answer those. There's the second one. Water moves from where to where? So you might want to stop and try to figure it out. Okay. And here's your third question. And once we get back to class then, if you have a question about what's the correct answer, I can tell you that. So that concludes the information on the third section of the fluid electrolyte unit, fluid deficit and excess.